you see that Krok-1 is coming, and this is the question that you should ask yourself if you're ready or not. But just to help you a little bit, I am pretty understand that we got a lot of issues about the quarantine, about the COVID-19 situation, about the distance learning. So we missed a lot, and just to avoid a big failure in the Krok-1, especially in our subject, because for sure I'm interested exactly in the pathomorphological passing of your Krok-1 component. And you should know, you must know that the pathomorphology, that's about the 14 up to 15, depending on the year, percent from the entire amount of questions. It's quite important. That's the huge investment to your successful mark. So that's why the preparation for pathology on Krok-1, that's an important step. That's why we are supposed to make 3 meetings. In fact, we divided these 3 meetings on 3 Google Meet classes. Each one is about to help 100 of students, because you are approximately 300. We decided to do that in 3 steps. So each time I will explain, me or my colleagues will explain the different MCQs. We will discuss about the different years of Krok-1 booklet, Krok-1 Q books, examples. And every time we will perform the recording of this video, then uploading them to the YouTube, and in such a way you can watch all of the parts of our workshops. So today is the first workshop. I called that in the manner of Dale Carnegie book. I guess you know, How to Stop Worrying, right? In this case, we call it How to Stop Worrying and Pass Krok-1 on Pathomorphology Successfully. And together with Jon Snow, I guess we will do that pretty nice. So let's start. The 2 days activity will consist of 22 questions. I prepared 22 questions from the last year Krok-1 preparation book. And in this type of activity, you will be requested, first of all, to help me with the answering of this question. After that, after your attempts, please write your answers in the chat. I will answer the questions correctly. So for sure, we will discuss about why it's correct, why yeah, please people, turn off your microphones, don't answer orally, write your answers in the chat. Do you know where is the chat? That's on the right panel. Okay, so thank you. You think that's D, and that's already familiar to you. So a 27-year-old patient presents with pathologic changes in the liver and brain. Blood plasma exhibits acute decrease in copper levels, while urine copper levels are elevated. The patient is diagnosed with Wilson disease. To confirm this diagnosis, it is necessary to measure activity of the following enzyme in the patient's blood serum. So let's think about this. The only relevant substance which is connected to the metabolism and transporting of copper in our body, that's the ceruloplasmin only. All others, in fact, they are not relevant to this case. And that's quite easy question. Just to remind you how it looks like, maybe you remember, maybe not. This is the injury of the liver with the Wilson's disease. You see the accumulation of copper stained with the specific staining, and you see the fatty changes in the hepatocytes due to the toxic injury. So in fact, the Wilson's disease is associated with the mutation in ATP7B gene and the lack of the production of the corresponding protein ATP7B. As a feedback, as a negative feedback, the lack of ATP7B produced the decrease of ceruloplasmin level in the blood. So that's obvious because no copper excreting from hepatocytes, no ceruloplasmin at all. So the correct answer is here. So people, please be in time. You're distracting a bit. Okay, let's continue. The next question. A mother of a 4-month-old male infant brought him to pediatrician with complaints of food rejection and weight loss. He started having trouble latching onto his bottle. He has also become extremely lethargic. Examination reveals diminished muscle tone in all 4 limbs and hepatosplenomegaly. An ophthalmoscopic exam reveals macular cherry red spots. During the next weeks, hepatosplenomegaly progresses. The boy fails to thrive, and he continued to reject food. Chest X-ray shows a reticulonodular pattern and calcified nodules. Biopsy of the liver shows foamy histiocytes. And Niemann-Pick disease is suspected. Which of the following is the most likely deficient enzyme in this patient? So please, what are your answers? Okay, you're right, C. You're right, C. Okay, in this case, we should, the answer is concluding quite obviously. You see, we have deal with the named disease, that's Niemann-Pick disease. You should remember that the Niemann-Pick disease, there's the thesaurismosis or lysosomal genetic disease, inherited disease, which is associated with the lack of the sphingomyelin metabolism. So since that, in this case, we have deal with the sphingomyelinase, the corresponding enzyme deficiency. So that's pretty obvious. Just to remind you, another type of storage disease, you see in this case, we have deal with the failure to degrade a metabolite due to inherited enzyme deficiency. Another example of sphingomyelinosis, that's the Tay-Sachs disease. In this case, we have deal with the injury of the brain. In our case, in Niemann-Pick disease, we have deal with the injury of other organs. And the correct answer, yes, that's C, sphingomyelinase. Next question. Autopsy of a man who served on a nuclear submarine. Nuclear submarine, you see the keyword, revealed the following pathologies: bone marrow atrophy, the corresponding term is the panmyeloptosis, anemia, leukopenia, thrombocytopenia, lymphocytic disintegration in the lymph nodes, spleen, gastrointestinal lymphatic system, then hemorrhages into the adrenal gland. What disease had developed in this case? For sure, that's, yeah, you were writing about the D, acute radiation sickness. Let's check it one by one. For example, vibration disease definitely is, maybe it could be associated with some activity on the nuclear submarine, but in our case, that's not so obvious. Acute anemia. Okay, well, if it's only acute anemia, why we have deal with the lymphocytic disintegration, leukopenia together with that. So together with that, that's not only the anemia, which is isolated. We also have deal with the lack of the growth lack of the hematopoiesis in all branches of hematopoiesis. You see, there's not only RBCs involved in this process, also white blood cells, platelets, and others. So that's not leukemia because there is no proliferation of the tumor cells from bone marrow. For sure, that's not decompression sickness because there was no mentioning of the decompression in the submarine, and obviously that's the acute radiation sickness as the correct answer. Next question. 34-year-old man died in a comatose state. According to his family, after a business trip to an African country, again, African country, you see the keyword, the geographical connections. See another connection, that's the comatose state, the keyword here. And another connection that he developed periodical jaundice attack. Periodical jaundice attack is something intermittent jaundice, what it could be. Autopsy shows the following: dense enlarged spleen with state black pulp, so the black coloration of pulp, what it could be. Enlarged plethoric liver, gray-black on section, again, see gray-black phase in the organs. Cerebral gray matter is brown-gray, again, brown-gray appearance. Cerebral white matter contains numerous small hemorrhages. Which infectious disease could be suspected in this case? So you answered B, and let's think. The formation of the black pigment is associated with, basically we call it hemomelanin. This is so-called hematine associated with malaria. Yes, malaria, because malaria in fact is associated with the intermittent hemolysis, and that's not cryptococcosis, that's not the herpetic infection, that's not the meningococcemia, and neither prion infection. That's only malaria, which is a correct answer in this case. So the hemolysis that lead to intermittent jaundice and that lead to formation of the hematine, the result of the iron pigment deposits. Next question. Yeah, Yasmin, that's hemomelanosis. Yeah, that's the so-called malaria pigment. 6-year-old girl presents with acute onset of a disease. She develops sore throat and high temperature that were later accompanied by a punctate skin rash. Oral examination reveals acute pharyngeal hyperemia, raspberry tongue, and enlarged bright red tonsils, with dull gray and yellow foci that spread to the peritonsillar tissues. The submandibular lymph nodes are enlarged. What disease are these changes characteristic of? That's measles? No. Why not measles? You wrote the C. Okay, you expect the scarlet fever over here, but why not measles? Because in case of the measles, we have deal not with such kind of the symptoms like red tonsils or raspberry red tongue. We expect the Koplik spots formation, right, in the prodrome period, and later we will see the rash again, but not such kind of a rash. It will be developed rather from the trunk, but not from the face. Then laryngeal diphtheria. There are some similarities with the pharyngitis here, but in fact it would be the films, the gray yellowish films on the surface of the tonsils, which are hardly to detach from the mucosa, and they leave the, as you remember, the ulceration after detachment. In this case, that's not about this story. Then meningococcal nasopharyngitis. Moreover, in case of the diphtheria, we don't have any deal with the rash. Meningococcal nasopharyngitis. Okay, in this case, we don't have involvement of the nasal area, so they got only pharyngitis, and also the some such kind of the raspberry tone that's not characteristical for the meningococcemia. And also we see the development of the widespread rash all over the body. In case of the pharyngeal diphtheria, again, as well as in case of the laryngeal diphtheria, there's just a different localization. So look at this. That's the raspberry tongue. You see the rash on the skin, on the limbs, on the back, on the trunk, and on the cheeks. So for sure, this is the scarlet fever, streptococcus. Yeah, so that's the streptococcal infection, which is characteristic for the infant period. The next question: 40-year-old woman dies of intracerebral hemorrhage after the hypertensive emergency. During an autopsy, the pathologist revealed severe obesity, excessive body hair, and white purplish stria on the abdomen. Microscopic examination of pituitary gland reveals hyperplastic acini populated by a homogeneous cluster of deeply basophilic cells. Which of the following was the most likely underlying disease? Unfortunately, there is no Cushing syndrome in the distractors. It could be very difficult for you in that case, because for sure we have deal with the Cushing disease, and sometimes for you it's very difficult to distinguish Cushing disease and Cushing syndrome. Why is Cushing disease? Because we have deal with the primary source of the injury of the adrenocortical system, the adrenocortical stimulating hormone. That's the hormone which is producing in the pituitary, and in this case we have deal with the tumor of pituitary gland. That's the adenoma that you see that on MRI, and for sure the correct answer, that's Cushing disease. And all the characteristic symptoms which you can see over here, the same you will notice in case of the Cushing syndrome, like hypertension, like the stria, like the body hair, hirsutism, obesity. That's the same symptoms in case of the Cushing syndrome, but for the Cushing disease, the primary injury is in the pituitary gland, and the proof for that, that's the presence of adenoma. Next question: 38-year-old woman who was diagnosed with systemic lupus erythematosus 3 years ago comes to her physician with a complaint of facial swelling and decrease in urination that she first noticed 2 weeks ago. She currently takes azathioprine and corticosteroid. Her vital signs show blood pressure. You see increased blood pressure, pulse, the temperature is normal, and respiratory rate 15 per minute. On physical examination, the doctor notices erythematous rash on her face exhibiting a butterfly pattern. That's the tip for you: butterfly pattern, and association with the SLE, sure. The laboratory studies reveal hypercholesterolemia, hypertriglyceridemia, and proteinuria. Which of the following is most likely mechanism of SLE complication in this patient? The only thing that you have to remember in this case, that's, I mean, just for this correct answer, to making correct answer in this MCQ, is to understand is the understanding of the pathophysiology and of this disease, pathogenesis of this disease. Pathogenesis of this disease is associated with what? Yeah, you answered D, immune complex mediated glomerular disease. You see the injury of the glomerular apparatus, which is associated with the hypercholesterolemia, hypertriglyceridemia, and proteinuria. So all these components can help us to conclude that this is exactly the glomerular disease, the lupus nephritis development. And for sure, it's associated with immune complexes formation, which is the characteristic pathogenesis of SLE. Next question. 30-year-old woman developed facial edemas. Examination detected proteinuria, you see, hyperproteinemia, dysproteinemia, and hyperlipidemia. Such combination of signs is characteristic of nephritic syndrome, chronic pyelonephritis, acute kidney failure, chronic kidney failure. Okay, what you should remember about that. First of all, if we're talking about some presence of edema, if we see the development of proteinuria, hyperproteinemia, dysproteinemia, and hyperlipidemia, and you don't see any mentioning about the hematuria, right? They're talking basically about the nephrotic syndrome, not nephritic syndrome. In case of the nephritic syndrome, we will rather see the development of the hematuria, but in this case, we see the issues only with the hypertension, facial edema, hyperproteinemia, and hyperlipidemia. That's the injury of the glomeruli, which lead to the nephrotic syndrome in this case. And for sure, that's not the acute kidney failure. Then we will rather see the oliguria. That's not the chronic pyelonephritis. Then we will rather see the some changes in the urine, like the leukocytosis. They're not chronic kidney failure, which would be the, again, could be associated with the nephrotic syndrome, but that's more complex condition. That's not so precise, which is exactly associated with the proteinuria. Nephrotic syndrome, for sure. That's the correct answer. Next question. Autopsy of a 49-year-old woman who died of chronic kidney failure shows small, dense, striated kidneys with areas of hemorrhages. Microscopically, nuclei of epithelial channels contain hematoxylin bodies. Glomerular capillaries resemble wire loops, have thickened basement membranes, and in places contain hyaline thrombi and foci of fibrinoid necrosis. What is the most likely diagnosis? So, first of all, that's the chronic condition, chronic kidney failure. What is the cause of that? It could be different things, but in our case, we have to deal with the woman. That's the risk category, the gender risk category for the systemic lupus erythematosus. You remember that, I guess. Also, we see the keyword, that's the wire loops of the appearance of the capillaries in the glomeruli, and that's the strong connection with the SLE nephritis. What else? You see the fibrinoid necrosis and hyaline thrombi, which are not so specific for this disease. But anyway, with all of the factors, which all of the symptoms mentioned above, we may conclude that this is B, that's systemic lupus erythematosus. Why not the rheumatism? Rheumatic fever, basically, they could be involved, the kidney could be involved in that case, but we don't see any mentions, that very rare though, but we don't see any mentioning about the Ashov bodies. Atherosclerosis. Okay, why then the fibrinoid necrosis and wire loops? In case of atherosclerotic nephrosclerosis, we rather see the decrease of the blood perfusion over there. Atherosclerotic nephrosclerosis, basically caused by hypertension. We don't see mentioning about the primary hypertension in this case. And amyloidosis is basically associated with the accumulation of the amyloid masses within the glomeruli. So B, that was the correct answer. Next question. In the course of an urgent surgery, the vermiform appendix of the patient was excised. It must be easy. Everything was connected with appendix is easy, right? The appendix was acutely distended and gray-black throughout its whole length. Please notice the color. In the distal segment of defect of the appendix wall was detected, through which a foul-smelling gray-brown, okay, foul-smelling, some stinky thing happened, and gray-brown substance was being discharged from the appendix lumen. Histological analysis shows necrosis of the appendix wall with the hemorrhagic foci. Lumen of the mesenteric artery is filled with the thrombus. What type of appendicitis is? Very easy, I guess. That's not chronic for sure, because we see the acute injury of the appendix vermiformis. What about the phlegmonose? It could be, but we don't see any mention about the pus formation, about the purulent component. Rather, we see the necrotizing of that. So this necrotizing event, for sure, suggesting us the most dangerous, the most profound type of acute appendicitis. That's acute gangrenous appendicitis. That's the correct answer. Well done. 60-year-old man with a history of hypertension, diabetes, and hyperlipidemia has a sudden onset of right-sided weakness. By the time the ambulance arrived, he had difficulty speaking. Okay, right-sided weakness and difficulty speaking. Unfortunately, the patient died within next 2 hours, and an autopsy was performed immediately. The gross examination of the cerebral left hemisphere showed brain swelling, widened gyri, and poorly demarcated gray-white junction. Which of the following is the most likely cause of this patient's death? A. Intracerebral hemorrhage. Who think A? No, for sure not A. There is no mentions of the hemorrhage. This just see the brain swelling. We see the poorly demarcated great white junction. And what else? What else? Okay, so demarcated. What is demarcated? Poorly demarcated, in this case, great white junction. So that's rather, yeah, and for 2 hours, it's not what I should say. You see, since we don't see any, in fact, the symptoms, clinical symptoms could be the same both for hemorrhage and for the ischemic stroke, especially for such kind of the background with the hypertension, diabetes, and hyperlipidemia. It could be the same story as the background, I mean. But in this case, we don't see yet any demarcated foci of the injury, like infarction area or bleeding or hematoma. Neither abscess, cyst, or tumor. So we just excluded that from the beginning. We just have to choose between A and B. Why it's not the hemorrhage? Because we don't see the hemorrhage. Hemorrhage will appear immediately. We don't need any time for its evolution, for its development. But for ischemic stroke, you should remember that necrosis is developing quite long, and that's why the 2 hours is not enough to form some kind of the visible, grossly visible necrosis. In such a way, we just see only poorly demarcated great white junction. However, it's pretty visible on MRI. That's why we must conclude that this is ischemic stroke for sure. Next question. Autopsy of 30-year-old man shows enlarged spleen. You see 900 grams, enlarged liver, 4 kilos, and enlarged lymph nodes. Bone marrow of the femoral shaft is bright red and moist. So it's rich, fleshy. Microscopically, in the liver, they found the thick infiltrates located mostly along the portal tract. Along the portal tract. That's not like the diffuse infiltration of the hepatocytes, only along the portal tract. The infiltrates consist of juvenile hematopoietic cells with, notice that, round nuclei and thin layer of cytoplasm. And you see no hours rods in this case. You see the no hours rods, just thin cytoplasm and round nuclei. Which disease can be suspected? So it could be a chronic myeloid leukemia or lymphocytic leukemia or acute lymphoblastic leukemia or acute myeloblastic leukemia or generalized lymphogranulomatosis. Let's see. That's chronic lymphocytic leukemia. First of all, in case of the acute lymphoblastic leukemia, we should pay attention on the age of the patient. And you must remember that acute lymphoblastic leukemia is basically associated with the childhood, not with adults. How we excluded the, okay, now we excluded acute lymphoblastic leukemia, right? Yeah, and for sure, this is the leukemia. This is the leukosis. That's not the lymphogranulomatosis. We got the systemic injury of hematopoietic organs, including the central organ of hematopoiesis, the bone marrow. In case of the lymphogranulomatosis, we don't have the injury, the involvement of the bone marrow. So why it's not the chronic myeloid leukemia? Because we don't have deal with the outer rods, neither acute myeloblastic leukemia, no chronic myeloid leukemia. That's only the round nuclei and thin cytoplasm. So in this case, we have deal with the chronic lymphocytic leukemia. Okay, yeah, thank you, Yasmin. Yeah, less than 14 years. That's the more characteristic for the acute lymphoblastic leukemia. Autopsy of 3-year-old child shows a tumor in the cerebellum. Tumor in the cerebellum and 3-year-old child. I guess the answer is pretty obvious, right? You see, the tumor has no clear margins separating it from surrounding tissues. You see, if you don't see any clear shape of the tumor, you can consider that there is infiltrative growth of this tumor. Thus, it's most likely the malignant tumor. Histologically, it's made of small atypical cells with hyperchromic nuclei. This tumor is most likely E. That's E, medulloblastoma, and I guess I don't explain it too much. So, glioblastoma, it's more characteristic for adults. Sarcoma, cancer metastasis, again, for 3-year-old child. Okay, it's possible, but not likely. Medullary sarcoma, again, why? So for 3-year-old child, and for the specific localization, that's the cerebellum worm lobule. So that's exactly the localization of the medulloblastoma, and E is the correct answer. Next question. Patient has gradually developed a skin plaque on his face. In the center of his plaque, there are necrotic patch and an ulcer. Histopathological analysis of the biopsy material reveals proliferation of atypical epithelial cells with large number of pathologic mitosis. What is the most likely diagnosis in this case? Yeah, please. Okay. Okay, let's check that. Skin cancer, sure. You see the atypical epithelial cells. That's quite easy. Proliferation of atypical epithelial cells with a large number of pathologic mitosis. No doubts, we have deal with the epithelial tumor. That's the cancer, carcinoma. That's not sarcoma. That's not papilloma, because papilloma, that's the benign tumor. That's not fibroma, that's benign tumor of the mesenchymal region, and trophic ulcer. That's not tumorous process. That could be, for sure, it could be the regeneration of the surrounding epithelium, but without ectopism and without pathological mitosis. However, ulceration of the skin cancer is a very common thing. So that's why please consider these facts and distinguish trophic ulcer with skin cancer. The differences in the ectopism and the presence of the uncontrolled proliferation. Next question. 63-year-old man suffers from esophageal carcinoma, presents with metastasis into the mediastinal lymph nodes and cancerous cachexia. What pathogenic stage of neoplastic process is observed in the patient? Okay, in this case, you see the stages of the process: initiation, promotion, progression, and transformation. That's the stages of carcinogenesis, and with each stage is corresponding to the very specific appearance of the tumors. For example, in case of initiation of tumor, there is no tumor at all. It's just the primary mutation and primary proliferation, which are not visible and which are don't have any clinical impact at this stage. Promotion. Again, the promotion, that's the that appearing in the very beginning of the tumor development. Transformation, that's some kind of the transformation of the tissues and cells, which again occurring on the beginning of the cancerous process. But progression, this is what exactly we see. Then the tumor is beginning to grow. Please turn off the microphones. Yeah, thank you. Especially with such kind of the events like metastasis, cancerous cachexia, and you see the development of this tumor for sure is associated with the tumor progression. That's the C, correct answer. Next question. Histological analysis of a biopsy skin sample obtained from 24-year-old patient detects caseous necrosis. Connection. Find the connection. Surrounded with cellular infiltrate consisted of lymphocytes, among which there are single giant cells, proliferation of connective tissue, and endovasculitis are observed. Characterize this pathologic process. Okay, 1, 2, 3. 1, 2, 3. D, proliferative granulomatous inflammation. Excellent. For sure, the caseous necrosis in the center, cellular infiltrate with lymphocytes and giant cells. This is what we consider as the granulomatous inflammation. No other options in this case. Abscess, that's the purulent inflammation. Proliferative interstitial inflammation, we will see diffuse infiltrate with lymphocytes and macrophages, but not localized. Ichorous inflammation, in fact, that's gangrene formation, the necrosis. Catheteral inflammation must be connected to mucosa. It's basically the acute, very rarely chronic inflammation. Okay, next question. Autopsy of 58-year-old man who for a long time has been drinking alcohol in large amounts and died at home is being conducted. Macroscopically, the right lung is dense and enlarged. Its tissue is gray and homogeneous on section. His pleura is covered with grayish membranous deposits. Microscopically, the alveolar cavities contain fibrin threads, neutrophils, and hemolyzed erythrocytes. Make the diagnosis. Okay, yeah, that's the like this pitfall of the translation, because basically conventional term for this is lobar pneumonia. Krupel's pneumonia, that's some French term which finally strongly attached to the lexic, medical lexic in Ukraine. So we call it Krok-1 pneumonia, but you must remember that in English it must be pronounced as the lobar pneumonia for sure. Without any doubts, we see the involvement of the lobe, right? So right lung is dense and enlarged. There is no involvement of the left lung. That's one-sided pneumonia. So focal pneumonia or interstitial pneumonia basically associated with the bilateral injury. In this case, we see only the right lung involvement. Then we see the gray and homogeneous on section, and pleura is covered with grayish films. These films, that's the pleuritis. And another alternative name of this pneumonia, that's the fibrinous pneumonia or pleuropneumonia. So also it suggests us the correct answer is A, Krok-1 pneumonia. For sure, that's not tuberculosis and not caseous pneumonia because it's associated with the acute exudative inflammation, not proliferative. 39-year-old man underwent a surgery for peptic ulcer disease of the stomach. He died 7 days after the surgery. On autopsy, the peritoneal layers are plethoric, dull, and covered with massive yellow-green membranous deposits. The peritoneal cavity contains approximately 300 milliliters of thick yellow-green fluid. Yellow-green fluid was that. Which pathologic process was detected in the peritoneal cavity? I guess that's pretty easy. That's not serous peritonitis. Otherwise, we will see the translucent, transparent, clear liquid, like resembling the serous fluid. Fibrinohemorrhagic, there is no mentioning of the hemorrhages over here. Serofibrinose, again, why we see the pus, the yellow-green fluid, right? Peritoneal commissures, there's fusions, peritoneal fusions. We don't see any fusions over here. That's acute process, right? And the only relevant answer, that's the fibrinopurulent peritonitis. Why fibrinopurulent? Because you see the a mixture between the pus formation and the formation of the membranous deposits, which are covering the guts, which are covering the intestine. That's the correct answer, B. Great. Original lymph nodes surrounding an infected wound are enlarged. Histological examination shows increased number of macrophages, lymphocytes, and lymphatic follicles in the cortical layer of the lymph nodes, as well as a large amount of plasma cells. What is the process in the lymph nodes is indicated by these histological changes. That's quite easy. This is the non-specific changes of any lymph node which are contacting with the external antigens, with the infection, something like that. So you see, infected wound, right? This is not about transplant rejection, right? This is not about the neoplasia. It's not about the congenital deficiency or acquired deficiency of lymphoid tissue. In this case, we have deal with the antigen intake via the wound. And hence, logically, that's the antigen stimulation as the correct answer. C is the correct answer. Perfect. Let's go further. 65-year-old woman presents to the emergency department because of shortness of breath and chest pain that started a few hours ago. She didn't have a fever, expectoration, or any accompanying symptoms. She has a history of right leg deep vein thrombosis and occurred 5 years ago. Sometime later, she dies of severe respiratory distress. A pulmonary autopsy specimen reveals red, loose mass that is lodged in the bifurcation of the pulmonary trunk with extension into both left and right main pulmonary arteries. Which of the following is the most likely diagnosis? No doubts, this lodging of the mass red loose mass, right? That's especially with the association with the deep vein thrombosis, right leg deep vein thrombosis, suggests us the only correct option, which is B, right? That's thromboembolism. Notice and don't be deceived with the presence of the you see, like the other cases, other background diseases, because in this case the only thing that caused the deep vein thrombosis, it could be different diseases that may lead to the stable immobilized condition of the patient, which may spend a lot of time in hospital. This immobilization may lead to the formation of the deep vein thrombosis after the surgery, after the emergency room for a few weeks. There is a risk, increasing risk of the thromboembolism development. B is the correct answer. Autopsy of a man, quite short test. You see who had been suffering from mitral stenosis, reveals dense brown lungs. Dense brown lungs. That's it. So I guess the answer is pretty clear. Dense brown lungs, we call it brown induration of lungs. Brown induration of lungs due to the mitral stenosis or other, a lot, don't be connected strictly to the mitral stenosis. It could be mitral insufficiency. It could be aortal valve failure. It could be chronic left ventricle failure after the myocardial infarction, like post-infarction cardiosclerosis. It could be different conditions that lead to the chronic left ventricle failure. All of these conditions are leading to the chronic venous congestion in the pulmonary circulation, hence development of the brown induration of lungs with hemosiderosis. Hemosiderosis, that's only the part of this process because the increased density is associated with the fibrosis, right? So A is the correct answer. Autopsy revealed a large wedge-shaped patch of a dense dark red tissue with clear margins in the upper lobe of the right lung. Histological examination detected their necrosis of the alveolar walls. The alveolar lumen is tightly packed with erythrocytes, which process occurred in the lungs. Is it just hemorrhage or hemorrhagic infarction, or gangrene? So look, gangrene could be developed further, but we don't see any mentioning about the contamination and the black coloration and the presence of the microbes, etc., and other attributes of the gangrene. Carnios degeneration. Carnios degeneration associated with the increased density and local development of the fibrous tissue on the place of the lobar pneumonia. Atelectasis, that's the collapse of the lung. We don't see any collapse here. Hemorrhage, just simply the hemorrhage. No, for sure not. That's the wedge-shaped patch with the necrosis, with the clear margins. And that's the result of the small-sized thromboembolism of the branches of pulmonary artery. As a result, hemorrhagic infarction. Why hemorrhagic? You may maybe remember that there are the different sources of blood supply of the lungs, and in organs with the multiple sources of blood supply, we may expect development of the hemorrhagic infarctions rather than pale infarctions. Okay, people, it was the last MCQ. With that, I wish you good luck on the Krok-1. In appropriate time, I will perform the second for next 10 100 students another workshop. I guess it was helpful for you, but now please don't leave. I got something for you. I prepared the surprise. So since you listened to me pretty cautiously, I want to check it, and I want to send you Just give me a moment. I want to send you a link. A link. Okay, just give me a moment. I just can't. Okay. So please look at the chat. Do you see the link? Yeah, please.
Yes, sir.
Follow this link. Follow this link and start to perform self-assessment. This you can repeat this MCQs several times. There is no limitation in the in time. There is no marks for that, so feel free to answer that. And just check yourself, because that's the same questions what I presented to you today. So with that, thank you so much. Thank you for your attention. And yeah,
Thank you so
guys,
much for
please, good luck and pass, at least pass pathomorphology as the best subject in the Krok-1. But in fact, I wish you to pass Krok-1 successfully at all. Doesn't matter which subject. So please pass it, just pass it. Okay, I'm crossing my fingers and I hope, my big hope on you. Good luck and my best wishes. Bye-bye.
bye.